pathogens, E. coli dominates, accounting for 75 to 90% of uncomplicated UTI and around 50% of complicated UTI. One thing to be aware of is the rise of ESBL producers in UTI, specifically Klebsiella. In some facilities, ESBL producers now account for up to 42% of isolates. And really, the practical implication of this is culture before treating suspected ESBL. Other organisms to keep in mind is Enterococcus accounts for around 10 to 15% of complicated cases, and Pseudomonas in catheterized or recently hospitalized patients. So moving into empiric therapy, for outpatient uncomplicated cystitis, the first-line agents are macrobid 100 milligrams twice daily for 5 days, as long as creatinine clearance is at least 30, and Bactrim double strength twice daily for 3 days. Augmentin is also an acceptable option, and fosfomycin is your single-dose ESBL E. coli option, and that should be reserved for the ESBL E. coli. For pyelonephritis, you need agents that achieve renal parenchymal concentration. So ciprofloxacin or levofloxacin are first line, but make sure to check local resistance patterns, along with possible QT prolonging DDIs for patients. And then another alternative is Bactrim for 7 to 10 days if cultures come back susceptible. And then one more practical note that comes up is don't repeat urine cultures after treatment if symptoms do resolve. So the goal in this population is clinical cure, not microbiologic eradication. So a positive culture in an asymptomatic resident doesn't equal treatment failure, and really chasing treatment for that result can lead to harm. Okay, so this is an MDR reference table, and there's just a few things that I want to flag on this. So the first is the ESBL enterobacterales. So macrobid and Bactrim will still work for cystitis if susceptible. For Pylobactrim is an acceptable option, or fluoroquinolones if susceptible, and step-up therapy to a carbapenem if concerns for toxicity or resistance. And then for MDR Pseudomonas, I have some of the first-line agents listed, but these types of infections with the use of these agents really should have an ID consult to optimize treatment regimens. And then the key MRSA point at the bottom, despite MRSA colonization rates up to 36%, MRSA really only accounts for around 2 to 3% of UTIs. So with that, empiric MRSA coverage in UTI should really be risk-based rather than routine. So patients with a prior MRSA UTI or known colonization with indwelling catheters are examples of people who would qualify for that empiric coverage. Okay, moving into special situations. The first one I'm going to go over is catheter-associated UTI. So many of these patients can be managed with oral therapy or step down quickly to oral options. And these oral agents include fluoroquinolones, so Cipro 500 twice daily for 7 days, or levofloxacin 750 for 5 days. Other options include Bactrim or oral cephalosporins like cefpodoxime or cefabutin. The cephalosporins are a good step-down agent, but they shouldn't be used if ESBL is a concern. For IV therapy without sepsis, third or fourth generation cephalosporins, Piptazo, or IV fluoroquinolones are preferred over carbapenems for stewardship reasons. Carbapenems really should be reserved for patients with sepsis or septic shock. And then just to reiterate, ertapenem would be an IM option here, but not if Pseudomonas is on the differential. And one more point on the slide, in catheterized patients, nearly 100% will have bacteriuria, but this alone is not UTI, and treatment should be reserved for patients with at least 1,000 CFU per milliliter plus UTI symptoms and no other source of infection. So that last point kind of segued into this next special situation that I'm going to discuss. So asymptomatic bacteriuria is one of the most common reasons antibiotics are inappropriately prescribed in long-term care settings. And the data on its harm is pretty substantial. So treating ASB does not reduce mortality or sepsis. It has no sustained microbiologic benefit. but it has been found to cause more C. diff, more resistance, and more adverse events. Up to 50% of long-term care residents have ASB at any given time, and of that 50%, only 16% will meet criteria for UTI. And despite all of that, 75% of them will receive antibiotics. So overall, the bottom line is that in the elderly, treating ASB causes harm without benefit. And for our last special situation, we're going to be discussing urine PCR testing. So the 2025 PulpMed consensus statement was very clear in recommending against routine use of urine PCR for diagnosing UTI in long-term care. And the reasons for this are layered. So PCR is oversensitive, it amplifies ASB and drives overdiagnosis. There are no validated thresholds, and the cost is about 585 per test versus $8 for a culture, so about 70 times higher. And much of the supporting evidence for PCR testing is industry funded, so that leaves room for a lot of bias. And then, most importantly, there is no demonstrated clinical benefit. In a population that's already overtreated for ASB, PCR makes the problem worse, and standard culture really should remain the diagnostic standard. Okay, now moving into pneumonia. So, pneumonia is the second most common infection in long-term care, and it is the leading cause of infectious death in this population. Incidence is 10 times higher in long-term care facilities than in community dwelling elderly. And by 2030, pneumonia cases in this population are expected to exceed 2 million annually. So, in other words, this is a really high volume, high mortality disease where empiric choice and duration both matter. So looking at the common pathogens, strep pneumoniae is still the dominant cap pathogen, accounting for 5 to 15% of cases. Atypicals like Mycoplasma and Legionella account for 3 to 11% of cap, and respiratory viruses are the largest single category at around 23%. In hospital-acquired and ventilator-associated pneumonia, the picture kind of flips. Pseudomonas climbs to 21 to 22%, Klebsiella 10 to 20, Staph aureus 10 to 18% for MSSA, and 5 to 10% for MRSA. In aspiration pneumonia, anaerobes account for 16 to 20%, and gram-negative enterics are the biggest culprit at 49%. And then one key point that I did want to mention is for nursing home acquired pneumonia, MRSA only accounts for 1 to 4% of cases. So routine empiric MRSA coverage is not recommended. Empiric coverage really should be reserved for validated risk factors like recent IV antibiotics in the past 90 days or prior MRSA infection. So moving into empiric therapy for CAP, if the patient has no comorbidities, which would be pretty rare in long-term care, amoxicillin 3 grams daily or doxycycline 100 milligrams for 5 days are first-line regimens. Macrolide monotherapy is reasonable if local resistance is under 25%. But if the patient does have comorbidities, so diabetes, CKD, chronic heart failure, immunosuppression, combination therapy is preferred. So a beta-lactam like Augmentin or cefpodoxime plus azithromycin or doxycycline is going to be first line. The respiratory fluoroquinolones like levofloxacin or moxifloxacin are monotherapy options, but these should absolutely be reserved for patients with very significant beta-lactam allergies just due to resistance and adverse effect concerns. And then just to circle back to the very first slide, 5 days is the optimal duration as long as the patient is showing clinical improvement by day 3. Okay, and the first special situation we're going to be talking about for pneumonia is MRSA and Pseudomonas directed therapies. So when the patient has confirmed MRSA pneumonia or risk factors, which are listed on the left, your two real options are vancomycin and linezolid. So vancomycin, gold standard, effective with decades of data, but also very nephrotoxic and requires AUC guided monitoring. And it has poor lung penetration in comparison to linezolid. So linezolid, on the other hand, has excellent lung penetration, 100% oral bioavailability, and inhibits toxin production. So the main trade-offs with linezolid is myelosuppression with very prolonged use and the popular serotonin syndrome question. So the question that comes up very frequently surrounding this agent is, should we be holding antidepressants if we are giving a course of linezolid? I will say that the short answer is that the actual incidence of serotonin syndrome with linezolid plus an SSRI or SNRI is well below 0.5%. There was a 2022 JAMA analysis, which is cited at the bottom, that found no significant difference in rates of serotonin syndrome between patients on antidepressants and those not on them. So in most cases, no, you don't need to hold the antidepressant for a short course, about 5 to 7 days of linezolid. But of course, education is important. Educate staff on signs and symptoms of serotonin syndrome. So like agitation, hyperthermia, clonus, tremor. For longer courses of linezolid or in patients who are on multiple serotonergic agents, discussion with pharmacy is reasonable. And then just to mention one absolute, daptomycin is contraindicated in pneumonia. It's inactivated by pulmonary surfactant, so it should never be used for any type of respiratory infection, regardless of susceptibility. And then moving into Pseudomonas pneumonia, risk factors meeting criteria for coverage are listed on the right again. Um, but first-line agents, if susceptible, include an anti-pseudomonal beta-lactam, so piptazo, cefepime, meropenem, plus a fluoroquinolone, with de-escalation to monotherapy once susceptibilities return. I'm not going to go super deep into MDR and DTR pseudomonas, but I have listed some regimen options on the slide, and again, in these cases, ID consult involvement is preferred. So, on to hospital-acquired pneumonia. All HAP residents should receive empiric coverage for Staph aureus and gram-negatives, including Pseudomonas, and some anti-Pseudomonal options are listed on the right. The main point I did want to make with this slide is that patients with recent IV antibiotics within the last 90 days or those at high mortality risk should get two different classes of anti-Pseudomonal agents, so they should be getting that double coverage, but single agent therapy is acceptable for the rest. Okay, so next up is aspiration pneumonia. So for this type of pneumonia, treatment really depends on where the aspiration event happened. For community-acquired aspiration, Augmentin 875 milligrams twice daily for 7 days is first line. Respiratory fluoroquinolones, moxifloxacin or levofloxacin daily are also alternatives with good anaerobic activity. And I did want to highlight that ciprofloxacin is not appropriate for pneumonia of any kind due to unreliable coverage against strep. So that is just something that to be aware of. Clindamycin is an alternative agent that should be reserved for severe penicillin and cephalosporin allergy. It has good anaerobic coverage, but definitely has a higher C. diff risk than other agents. And lastly, metronidazole is another alternative agent for anaerobic coverage, but it should never be used as monotherapy, and it is less preferred than other agents. And then I won't go too deep into HAP because typically aspiration events are witnessed in the hospital and treated there. But in summary, again, you will need an anti-pseudomonal agent. And then similarly, if meeting the criteria for MRSA coverage, vanc or linezolid is appropriate. Okay, moving on to our last slide for pneumonia, COPD exacerbations. So the 2026 Gold Report was just recently published, and it keeps a familiar recommendation that not every exacerbation needs antibiotics. Antibiotics are really only indicated when purulent sputum is present. If it is not present, you treat with bronchodilators and a prednisone burst, 40 milligrams daily for 5 days. When antibiotics are indicated, the preferred first-line treatment is Augmentin or Doxy for 5 days. Alternatively, a respiratory fluoroquinolone can be used, but really should be reserved for repeat exacerbations or suspected resistance if possible. Okay, last section is skin and soft tissue infections. So these infections are the third most common type of infection in long-term care. MRSA colonization is 16 to 23% in these residents, which means a lower threshold for MRSA coverage when the picture does fit. And the single most useful clinical distinction is purulence. So non-purulent should receive streptococcal coverage, and purulent receives MRSA coverage. And that difference is what really drives the table on this slide. So first, I'll go through the more common severities seen in long-term care. So for mild and non-purulent and outpatient cases, first-line agents include cephalexin, dicloxacillin, or augmentin for 5 days, and clindamycin if allergic to penicillin. For mild purulent cases, the first-line agent includes Bactrim 1 to 2 double-strength tabs or doxycycline for 5 to 7 days, with cephalexin added if you are worried about strep coverage also. For moderate or severe purulent, these are the ones that are going to need IV therapy. So vancomycin, daptomycin, or ceftaroline, and then step down to oral agents. And duration of treatment is 7 to 14 days. And these cases oftentimes do need inpatient treatment. And then I did want to highlight the bolded sentence at the bottom of this slide. True cellulitis typically presents unilaterally, and bilateral lower extremity cellulitis is very rare. So when you see bilateral redness in both legs, the literature does show that 30 to 39% of this presumed cellulitis is actually pseudocellulitis, and most often stasis dermatitis, which is inherently bilateral. So that bilateral presentation really should be a red flag for an alternative diagnosis and an indication to escalate antibiotics. And then this slide just goes over common primary pathogens in skin and soft tissue infections and the most common type of infection that they are responsible for. There's a few things I'd like to point out. The first one is that for MSSA cellulitis, incision and drainage is the first line option, and sometimes that is enough, and antibiotics aren't always needed. And then secondly, I wanted to point out that if covering for MRSA and using Bactrim or doxycycline, you must add coverage with the beta-lactam if concerned for group A or group B strep, due to both of those agents having unreliable coverage against those organisms. And then as for MDROs and SSTI, MRSA colonization is 36 to 42% in nursing homes. And again, that drives that lower threshold for MRSA coverage in primary SSTIs. So oral options are Bactrim, Doxy, minocycline, linezolid, clindamycin. IV options are vancomycin, daptomycin, or ceftaroline. And then for ESBL enterobacterales, this is pretty rare in primary SSTI, but definitely a real concern in pressure ulcers, diabetic foot infections, and chronic wound infections that have been previously treated. Bactrim or fluoroquinolones if susceptible, carbapenems otherwise. And just remember that ertapenem is also an IM option there also. MDR, Pseudomonas, and VRE are also both really rare in skin and soft tissue infections, but I've listed some acceptable regimens. But similar to UTI and pneumonia, if these pathogens are identified, an ID consult is needed. I see that like a Zoom user has like a hand up. I don't know if you want me to stop to ask a question.
I think we'll take questions at the end. You're almost done here.
Okay. Okay, so this is the last special situation to discuss regarding SSTI, and those are pressure ulcer infections. So the first thing that I did want to point out on this slide is that surface swabs are not reliable. Deep tissue biopsy or needle aspiration are the best options for actionable cultured data, and treatment with systemic antibiotics should only be initiated when systemic signs of infection or advancing infection is present. So otherwise, for mild cases, topical treatments are the first line. And if moderate in severity and requiring those systemic antibiotics, pathogen coverage should include MRSA, gram negatives, and anaerobes. And then I won't really go too deep into severe options, but in these cases, it's going to be inpatient treatment with an ID consult. Okay, so that was all that I did have. So just to pull everything together, I guess I'll just give you like three kind of takeaways. So the first one is shorter is better. 5 days for cystitis, CAP, COPD exacerbations, and uncomplicated skin infections, as long as patients are improving. Two, don't treat what doesn't need treating. So ASB, pressure ulcers without systemic signs. COPD exacerbations without purulent sputum, drained abscesses without surrounding cellulitis. Antibiotics are not indicated for that. And then three is match the drug to the bug. Cipro is not a respiratory fluoroquinolone. Daptomycin should not be used as a pneumonia drug. And bilateral lower extremity redness is unlikely to be cellulitis. But that is all I had for you guys. So thank you.
That was excellent. Thank you very much, Nori. There's a lot of information in there. Very, very good. Yeah, we do have it says Zoom user with a hand up. So, and I don't know who it is. So if you have questions, unmute and
Hi, sorry, I'm doing
that's
this
all
on
right.
a phone and I can't get my raised hand to lower.
Oh, it's all good.
But I
Did you
did
have a question?
enjoy. I did enjoy
Okay.
this. Thank you.
I think I can lower your hand. I got you.
I have sorry. I had my hand raised. I did
Okay.
have first of all, I really enjoyed this presentation. I hope we can get your slides because I can see myself going back to this again and again. I had a question regarding complicated versus uncomplicated UTIs or cystitis. For example, I had a patient just a couple days ago. They have nephrostomy tubes. We did draw a UA as well as a CBC. We don't have elevated white blood cell count, but we do have significant neutrophil elevation with bands. It's more than 8% bands, which is one of the criterias. And we do have more than the 1,000 of the bacteria. So it meets criteria, and they do have a significant clinical decline. The patient has, in the last 1 week, acutely stopped walking, and there is a significant clinical decline that is happening. There's mentation change, all of those things. So if I am able to, I do meet other objective criteria. I think that counts as complicated cystitis. So if I'm able to, and then when I draw the UA, I'm not able to get the lab to, or I wasn't able to at this time. They threw the sample out and then they didn't draw a culture at this time, or they didn't actually culture that. How do I proceed in this situation? Am I able to go ahead and treat empirically? That's where I'm stuck at this point.
Okay. Does anybody else want to take that? So basically, I think you have what you think is a UTI, possibly a complicated UTI, and you don't have culture data to guide you, and you're wondering if you can, I guess, clinically justify going ahead and treating empirically. Did I understand you correctly?
Sorry, I muted. Yeah.
Okay. Um, Anybody else want to take that? To me, I would treat empirically, and if I could get another culture before starting antibiotics, great. But you probably can't, I guess, if you feel
Yeah,
like the
I
person
can
is decompensating.
redraw it, but at this point, then that would delay me being able to start, right?
Well, you could draw the culture, go ahead and start empirically, and if the culture results came back with drug resistance, then
Mhm.
you could take a turn. Then
Okay.
you
All
could
right.
modify therapy.
Yeah.
I
Okay.
Any other thoughts?
And I would clearly document what symptoms make you think it is a UTI. Put that in there.
Okay. All right. Yeah. Thank you.
Greg, did you have a comment?
No, I just agreed with what you were saying. And one of the things to remember about antibiotics with treating urine infections is that the discs you use for sensitivity discs on the agar plates are based on serum levels of the concentrate of the antibiotic. And what you get in the urine are concentrated urine levels that are anywhere from 8 to 20 times higher. So oftentimes things that are even intermediate sensitivity are terribly sensitive at the concentration they get in the urine.
Okay, thank you. There was a question in the chat, and we'll just bring this out in case people didn't see the chat, asking about using doxycycline instead of metronidazole. And we're just wondering if either Jen or Nori, could you give us your thoughts on that? for aspiration pneumonia, I think, is what they were using it for.
Nori, do you want to go ahead? You did cover it. I did answer back in the chat. It was listed mostly for healthy adults with mild cases. They were used in combination with beta lactams. Go ahead, Nori.
Sorry, I was looking for the unmute button.
So the question is about using doxycycline instead of metronidazole in aspiration pneumonia. And that is pretty common. I see that done quite a bit, honestly. Metronidazole is kind of nasty, has lots of side effects, especially in our population. So is it all right to use doxy, or do we need to add?
Yeah, I was gonna say
them?
it is all right to use doxy. When I was back in the MICU at Denver Health, that's mainly what they used over metronidazole.
Okay. And Jen, you would add a beta lactam to that?
For anybody who has complications or comorbidities, I would definitely consider beta lactam added to it. Yes.
Okay. And do we have any other questions?
I have a question. This just came up yesterday. What is your approach to people who say that are allergic to penicillin and maybe they don't remember what the reaction was? So many of our first line therapies here are penicillins.
Ooh, Jen, I might let you take this one.
Yeah, that's a complicated question. I always am on the edge of retrying. I mean, if it wasn't significant enough to recall what the reaction was, I always cautioned the retry, just because I think those allergies get listed on there even when it's an upset stomach to something. So if it was a serious reaction, I just feel like we would definitely know more about it. I don't know. Anybody else have thoughts?
Yeah, there was actually a CDPHE in their antibiotic stewardship group. They do talks every 2 or 3 months, and this was actually one of the topics. And I don't remember the percentages, but the percentage of actual anaphylaxis and actual allergy to penicillins is pretty low. And there seems like there's been a push lately to actually challenge, do a penicillin challenge for a lot of patients, even in the outpatient setting.
Yeah, I remember that, Dr. Shepard. It was like 95% are not true allergies.
Yeah. Yeah. And just from my own experience, there's like 16% cross-reactivity with cephalosporins. So I usually feel a little more bold in challenging that. I do worry about the penicillins if it's an actual allergy. So I often will take the route of using a cephalosporin instead. That's kind of the chicken's way out. But I'm starting to wonder if we shouldn't actually, do skin challenges, skin testing or something like that. And in some cases, because yeah, it's such a prominent allergy in quotes, right?
Can I ask one follow-up question?
Sure.
So if you had someone who had both the penicillin allergy and a crossover cephalosporin allergy, how bold would you feel in trialing that person, or would you just go to something else?
Oof. If you're asking me directly, then my boldness kind of starts to go away. But most of these people are we're in a controlled environment, right? So we have that on our side. It just depends on the infection, how serious it is. Um, if somebody's septic, it's a different calculus than if someone's got, a skin infection that you could try clindamycin instead. So that's there. I'm copping out on the answer, but that's the best I can do.
Thank you. I appreciate the perspective.
Anyone else? Any other questions? We will have the slides. We'll put them up. These slides are packed full of info. It's a great slide deck. So I agree. There's some stuff in here that I'll go back on. And I think that first slide that you had kind of summarizes a bunch of stuff. And the one that I had the most trouble kind of turning or changing my habits on were how long do you give the antibiotic for? And it's taken me a few years to kind of start shortening that course from 14 to 7, and I'm down to 5 and 3 now. And it sounds like 5 is kind of where we are most of the time. for most of these infections anyway. Is that right? Okay. Rebecca, are you speaking to us? You're muted.
I just agree with you. And it's hard to change your practice. But I think once you do it, like you start realizing that shorter is fine. Usually people do really well with the shorter durations. So
Okay.
just agreeing.
So it doesn't, I don't think, I think Chad actually came on, but I had already started. So I texted him and apologized. So I hope he didn't have any updates. And I haven't seen that Jenny Albertson has jumped on. Jenny, are you there? There's a few
I
people
haven't
that,
seen Jenny.
yeah, there's a few people that are not listed by their name. So we potentially could stop a little early here today and give you back some of your day, unless someone has more questions. Okay. So again, reminder, Journal Club on
Can I ask
Thursday.
one last question? Sorry,
Sure.
if it's okay. On cellulitis, a patient is treated with IV antibiotics in the hospital. They step down to oral antibiotics. On the oral antibiotics, at the skilled level on day 2 or day 3, if the purulent discharge does get worse, is there room for escalating back up to IV antibiotics? And if the answer is yes, how many days of IV do we do, or do we stick to orals?
Nori, I'm going to let you or Jen take that one.
All right, finding the unmute. I think that's case by case for sure. And definitely, I assume we have ID involved. I think that sticking to orals is a great option for those skin infections once we have that step down. And maybe we would just carry the course out just longer than the 5 days at that point.
Yeah. I didn't have ID involved. I think they just had the hospitalist involved in the hospital, got 1 course of vancomycin and maybe 2 or 3 doses of Keflex, and got shipped to me. So that's where I was at. But I think next time I could probably call the pharmacist and utilize that.
Yeah, so Vanc or linezolid would be your 2 options there, right? If you really think you need that MRSA coverage. And just, I mean, from my experience, ID consults are not easy for me to get in long-term care.
Same.
I don't know if I can get them, but what I can get is the ID guys, at least around here, are always willing to take a phone call. I've curbside them, and they're actually very happy to do that. So just throwing that out there. If you can't get an ID consult, a phone call is just as good.
Thank you so much.
Yep.
I asked a quick question too, maybe along that kind of same theme. Could you highlight which antibiotics are equivalent, whether it's IV or PO, like which ones are kind of equivalent, and it doesn't really matter which way you're giving it? Because it's sometimes hard to get an IV in our space and make that happen.
Yeah, Nori, can you and Jen take that one? Obviously, vancomycin would be the one I'd take off the top of my head. Oral vancomycin is not going to get you anywhere, right?
I was thinking fluoroquinolones usually are equivalent, IV or PO, from what I know, but I just was curious from a pharmacist perspective.
Yeah, so if someone comes to us on IV vancomycin and they're coming from the hospital, what are our options to get them off that IV?
We generally don't, because we can use Vanco. Yeah. Go ahead, Dr. Gom. Was that?
I was going to say it's expensive, but you could use Zybox.
Yeah. I think we continue the Vanco 9 out of 10 times.
Yeah. And so IV levofloxacin and PO levofloxacin are relatively equivalent, right? I don't know if you can say that about Cipro or not. Are there any other where the IV and the PO are relatively equivalent that you can think of? Yeah, that's the only ones I can think of, unless somebody else has got some. Okay. All right. Anyone else with any questions? Okay. What time do we usually start? 1 o'clock? Okay. So 15 minutes of your time back. It was a great talk, though. Thank you very much. I really will refer to these. So I'm going to make sure we get them up on the website and make them available for everybody. So thank you, Nori, and congratulations on your upcoming graduation.
Thank you.
Yeah. All right, guys.
Everybody.
I think that's all we've got. Thank you, guys. Have a good day.
Yeah.
Stay warm.
Yeah.
Bye-bye.
Thank you all so much.
Nori, can you email me your slides? You still there? She left me.
Just lost it. That was a really good talk.
It
Great.
was packed full of stuff, so that was great.
Yeah.
All right, so we kind of fumbled through that. Next time I'll just give till 12:05, and poor Chad. He
No,
jumped on for like 10 seconds and he saw I think
he's
he
fine.
saw us talking and then jumped off.
They just gave us an update last month anyway, so I think everyone loves to have time back.
All right,
Hope
excellent.
you have a good
All right.
day.
Yeah, thanks for helping. Appreciate it.
Bye.
Bye-bye.